Thank you so much. Really privileged to be here today. As you just heard, I am a family physician, a rural generalist, practicing in Pincher Creek, and I'm speaking today from Beaver Mines, Alberta. I do want to acknowledge that I am a settler and I live and work on the traditional territories of Treaty 7, which is the Blackfoot Confederacy. And I also feel like I have to acknowledge just the grief and trauma that my Indigenous friends and colleagues have been facing over the last week with the discovery of the 215 children in a mass grave in Kamloops. And I am reflecting on we need to grieve with them, but also reflect and inform how we individually and all of our organizations can think about how we can act and enact the Truth and Reconciliation recommendations, particularly in health. And as a primary care physician who had 50% of her panel Indigenous, this trauma reverberates personally, and I think it's really important that we all recognize that. So thank you very much for that. And a brief presentation outline. What I'm going to talk about is the Collaborative Mentorship Network for Chronic Pain and Addiction, which is a primary care support for community practitioners. I'm going to review the objectives of this network, why we chose mentorship, what we're offering, and how it aligns with what's happening in the province. We've had some recent evaluations and what that's showing us, and some future plans and how that may impact primary care management of chronic pain. And so that brief history, and this is going to be really brief, basically the CMN came into fruition through the Primary Healthcare Opioid Response Initiative that I think was started in 2016, 2017. And with the realization the family physician group of peer that chronic pain and substance use disorders are very complex things that don't fit into a nice algorithm, and that mentorship is going to be really key in how we manage these within our practices. Initially, this mentorship network only included family physicians, and that was one of the glaring problems with the mentorship network, and it was identified by a lot of our mentors and mentees. And so we did go ahead and apply through the federal government substance use and addiction program to expand the mentorship network to our interdisciplinary team members. So so we went on to develop these very lofty objectives, but basically what we're trying to do is support integration of primary care and specialty care, support stepped care, and develop some foundational basic chronic pain and substance use disorder education in primary care, and then not just in family physicians and our support therapists, our pharmacists, our mental health therapists, because we can't do this alone. And most importantly, I think the inclusion of our persons with lived experience in all the educational components has made a huge difference. So basically, we're trying to develop a compassionate space for the development of capacity in individuals, in clinicians, in clinics, in PCNs, in that primary care, medical home, medical neighborhood space where we can all meet and learn from each other. And in my reading and research on compassion, we know that if we treat patients and individuals who live with chronic pain or substance use with compassion and with compassion to ourselves, their outcomes and our outcomes are much better, and we build resilience. So I often get asked, why chronic pain and addiction? Why are those paired together? And I think that the short answer is that some of the predisposing factors for chronic pain and substance use disorder are similar, but more alarming to me was in the Canadian Pain Task Force report, where a lot of the patients who had substance use disorder did relate to inadequate treatment in primary care of chronic pain. And so we need to look at that spectrum. And I think some of the things and the things we do in primary care to manage chronic pain also apply to substance use and that whole complexity. So I don't have to explain to this group, I don't think, as how common chronic pain of all different types is in Canada. So 20% of Canadians with chronic pain, huge cost to the healthcare system, and a huge cost socially to people that live with chronic pain, with the issues of stigma, with the issues of loss of work, social isolation, and those types of things. So it's a huge thing that as a family doc, I see all the time in my practice. So we're dealing with a very complex chronic condition that deserves to be considered that and needs the same types of resource. And I am hoping that through our mentorship network, we can provide those primary care supports to our medical home practitioners and our medical home neighborhood to support managing this condition in a better way. So how are we going to do that? So right now, we have sort of 4 major things that we're doing. So we have one-to-one mentorship. And so what that involves is matching people that have enhanced skills, either fellowship skills in addiction or chronic pain, or enhanced training in that area, with people who want to learn more about those specific areas. And we try to match those individually. This is self-directed. There's no time commitment, and you do not have to be in a mentorship network or a mentorship relationship to be in the network. We also have an online community discussion board and resource library, which we're developing. And we recently hired Dr. Leah Phillips to help us really develop that resource library, have high quality evidence-based tools, but also develop some knowledge translation plans to disseminate that. We have open educational events. Our last one was with Dr. Vincent Lam, looking at acceptance and commitment therapy. And that's open to all health professions, and you don't have to be, a member of the network. And then we have closed collaboration forums or detailed workshops for CMN members that occur monthly. Oh, sorry. No, that's a problem. There we go. So as far as the CME is, I just wanted to show you what, the variety of topics are, from alcohol use disorder to, better sleep and chronic pain, to evidence reviews and back pain, to therapies. And Dr. Rob Tanguay, no stranger to this group again, has presented. So, we get a diverse topics. The other thing that has been really popular and helpful in our evaluations, at least our members have said, are these one-pagers that we develop from each session. So they're one patient that you might want to keep on your desk. Now, we also want to shout out to Tracy Fossum and her group about developing this particular tool that is the most popular and downloaded one from our resource library on how to have the perfect appointment, what physicians need to know in managing chronic pain patients. This is just a brief information so you understand. We've got about 250, 260 members. And most people are either general members or mentees. you'll notice we only have about 45 mentors. And so they're working hard in these mentoring relationships. So we're always looking for more mentors. And so consider that an ask. The membership at this time is, vast majority is family physicians, but we have a large group of community pharmacists that are very interested in how we start talking the same language in managing chronic pain and substance use disorders, and how they can help their clients virtually and how they can communicate with us. We have a smaller groups of nurses and nurse practitioners and mental health professionals, and we are working hard at integrating, most importantly, our physiotherapists and OTs and clinical rehab staff. And so we'll be actively recruiting there. Interestingly, overwhelmingly more females than males, and interestingly as well, almost equal representation rural and urban. And I think that's a reflection of wanting increased resource in more resource poor areas in rural and remote areas. So in our evaluation, what have we seen? Has there been any benefit in the first 8 or 9 months of this interdisciplinary mentorship network? Well, we have had reports that the education has been highly relevant and has changed practice. That's self-reporting, so it's hard to say for sure. We have reports of decreased referral to specialty clinics, which is important from a health system point of view. From the mentor and mentee relationships, we are developing increased comfort in managing complex situations of all types, not just isolated to chronic pain or substance use disorders, but in managing just complexity and approach. And often our mentors are saying they're learning as much from mentees as they do, as they feel the mentees are learning from their mentors. The other benefits, CME credits. So, people are getting their continuing education credits, and the colleges recognize these educational events and mentoring relationships as being effective learning tools. And our mentors do get some financial reimbursements. So if you're at all interested, we're starting to see these changes, but what I really wanted to know when we started this is, how does this align to Alberta's programs, and are we making a difference in clinical practice? And so I think the alignment is clear with the Alberta Pain Strategy and the role that primary care needs to take. And I did want to talk about a quote that came from the Canadian Pain Task Force report in October of 2020, where it said, for most Canadians, the first point of contact within the health system for assessment of pain is a family physician or primary care practitioner, many of whom often lack the knowledge, skill, and judgment to treat chronic pain. And so that was a bit of a call out and a red flag to me. Initially, as a family doc, was a bit offended. But then, in reflection, I thought, my education had been small in chronic pain, although I was educated a long time ago, but also it made me recognize that we need to put some supports in primary care if we're going to manage this correctly. So it aligns with a lot of things. And I just want to have a shout out for something called the Agreement in Principle for Alberta's Care Plan for Chronic Pain Patients on Long-Term Opioid Therapy. The signatories on this include the College of Physicians and Surgeons of Alberta, the Alberta Pain Society, and Help Alberta's Pain, as well as every single primary care physician leadership group in this province. And this is a living document that is committed, a patient's medical home, and connecting our chronic pain patients with complex needs to primary care. It's a commitment to facilitate a culture change, to accept chronic complex patients living with pain to be cared for in a medical home and in our primary care settings. So the mentorship network is an attempt to build capacity in our primary care teams to take this on. This agreement is a unique and powerful agreement that no other province in Canada has. We're committed in this agreement and as the CMN to try to eliminate the stigma that chronic pain patients have in trying to access care in the healthcare system. It aligns with Alberta's and Alberta Health's sponsorship or education in trauma-informed care, and the importance of developing that compassionate space for us to care for patients with complexity. And so what does our future hold for us? So we have partnered with the Pain Foundations course from BC to supplement PACE's course from Alberta Health Services on substance use and pain to develop a sound foundation in pain education for interdisciplinary team members and primary care providers. These courses are web-based. They're about 12 hours self-paced. They're certified in patient-centered chronic pain management and pharmaceutical and non-pharmaceutical pain management strategies. And our hope is to offer these to individuals interested, to clinics that are interested, to PCNs who want to develop their chronic pain strategies and chronic pain management. And by offering it in those in that primary care and medical neighborhood, that we can build a basis of common language and skills. We have numerous collaborations starting to happen, both nationally amongst other networks that manage chronic pain and addiction in Atlantic Canada, in BC, and with the former Ontario Chronic Pain Network. We are working with the Calgary PCNs, who are way ahead, as often they are, with their chronic pain management. 5 of their PCNs have a PCN chronic pain program, a bit of a stepped approach where primary care refers to their PCN for chronic pain management. If it's more complex, it can go to a tertiary care, but then referred back to either the PCN or a primary care provider. And we work with Calgary PCNs in their PCN pain rounds. We have connections with other PCNs interested in developing programs and educational opportunities, both in substance use and with pain management strategies. We are also partnering with our universities, and these are more of a research base, but looking at some web-based cases that can solidify that chronic pain knowledge amongst teams or amongst a mentor and mentee. And it will offer us some information in whether what we're doing is actually making a difference in practice. And they're very complex cases developed with OLABs and with Dr. David Tops at the University of Calgary. We also are embarking on a research project looking at how mental models in the medical neighborhood affect patient care. So what we're talking about, and one of the most common things that we get asked from our pharmacist colleagues, is how do family docs think? How do they make a decision? And it has not been studied outside of formal teams. So how in the medical neighborhood do we work better and understand how each other thinks and how each other's roles impact our patients? And the final thing we're looking at is understanding how our networks are connected. And so we have primary care networks, we have a chronic pain and addiction network, we have a housing and harm reduction network. And so how do we interact, and how can we understand how they work, and can this help implement change across the healthcare system, particularly in primary care, which is notorious for being difficult to implement because we're so diverse. And then the final thing we found in our evaluation, and that we'll be studying, is the resilience that we're finding, particularly this year with the difficulties of COVID, the switch to virtual care, the ongoing polarization within the healthcare system and with COVID, that having that compassionate space to discuss everything has made a big difference in developing a tight community. And perhaps that resilience piece and the compassion is the most important thing that the network is offering. So what are our asks? We just want you to be aware that CMN is a free resource to your PCNs, to your community health practitioners. It's easy to join. It's a simple link. We're always looking for mentors from all professions, so please keep us in mind if you think you have something to offer, and we're open to any collaboration you think that is key in pushing forward excellent care and chronic pain management, particularly at that community level. So the bottom line is we're a compassionate community of practice, and we would love you to consider joining and to continue supporting this initiative and supporting chronic pain management in the community. So thank you very much. I hope my internet lasted. And if we have any questions, I think we'll go ahead.